So for today's session, what we do know that probiotics are not new. And yet there continue to be so many misconceptions and significant lack of understanding about probiotics by healthcare professionals and consumers alike. For today's session, that is led by Dr. Eamonn Quigley, who is recognized globally as an authority on the microbiota. We will explore some of those misconceptions, try to fill in some of the knowledge gaps, and help healthcare professionals understand how to responsibly select and recommend appropriate probiotics. As we are getting into Dr. Quigley's presentation, I'd like to take a moment to introduce Dr. Quigley. It's really such a feast to have Dr. Quigley with us, and I'm so grateful that he took time from his busy practice today to join us. Dr. Quigley is David M. Underwood Chair of Medicine in Digestive Disorders and Chief of the Division of Gastroenterology and Hepatology at Houston Methodist Hospital. Quigley.
Thank you very much, Dragan, and thank you for that very generous introduction. It's a great pleasure for me to be with you today. And on my first slide here, I hope you can see my learning objectives. I will certainly go through the definitions and I will touch on all these other issues as I go along, but I will not go through them one by one. Rather, I'll give examples along the way, which hopefully will illustrate each of these points. Now, we'll start with prebiotics. Now, prebiotics, of course, are not bacteria. They are other substances which promote bacterial growth. And over the years, there have been variable definitions of prebiotics, and this was perhaps the first one which was widely used, which defined a prebiotic as a selectively fermented ingredient that results in specific changes in the composition and or activity of the gastrointestinal microbiota, thus conferring benefit upon host health. This definition has been questioned more recently. For example, are these effects really selective? Probably not. And the other question that has been asked is, are the prebiotic effects really that specific, and does that really matter? So these are the questions that have been asked about prebiotics. First of all, can you really differentiate between beneficial and detrimental members of the microbiota when you give a prebiotic? Secondly, you need a diverse community for homeostasis, therefore it's probably a good thing to stimulate more bacteria than just one. And it has also been shown that key metabolic effects of prebiotics do not require selective fermentation. And also it's been shown that established prebiotics are not as specific as previously assumed. So more recently, it was suggested that a prebiotic should be defined as a non-digestible compound that through its metabolism by microorganisms in the gut modulates the composition and or activity of the gut microbiota, thus conferring a beneficial physiological effect on the host. Perhaps this is the most up-to-date definition, which again is produced by ISAP. And it's a simple one. So it defines a prebiotic as a substrate that is selectively utilized by host microorganisms, conferring a health benefit. And I think that is probably the most satisfactory definition. So what are prebiotics? So here's a list of the most commonly defined prebiotics: inulin, which has been around for a long time, fructose oligosaccharides, transgalacto oligosaccharides, lactulose, and human milk oligosaccharides, which of course are naturally occurring a prebiotic. Now, other substances have also been proposed to be prebiotics, but they're not widely accepted as such as resistant starch, pectin, arabinoxylan, whole grains, various dietary fibers, and even non-carbohydrates such as polyphenols, cyclophosphamide, metformin, or berberine. But as I said, the group on the left, starting with inulin, are those which are widely recognized as being prebiotics. Now, probiotics have been around for a long time, or probably described first by the gentleman on your right, Mechnikov, in 1908. Here, the definition has been pretty consistent over the years, and they're defined as live microorganisms, which, when administered in adequate amounts, confer a health benefit on the host. Now, other questions have been asked. Do you really have live live organisms, and I'll talk about in a few minutes the concept of postbiotics, which deals with dead cells, bacterial components, bacterial products, peptides, metabolites, and even bacterial DNA, which may all have biological effects. And some have suggested that we actually should use a broad term like pharmabiotic to include probiotics, postbiotics, synbiotics, etc. Now, postbiotics have very recently been defined, again by ISAP, as a preparation of inanimate microorganisms and or their components that confers a health benefit on the host. Postbiotics are deliberately inactivated microbial cells with or without metabolites or cell components that contribute to demonstrated health benefits. Purified microbial metabolites such as short-chain fatty acids and vaccines are not postbiotics. A postbiotic does not have to be derived from a probiotic for the inactivated version to be accepted as a postbiotic. The beneficial effects of a postbiotic on health must be confirmed in the target host, and implicit in the definition of a postbiotic is the requirement that the postbiotic is safe for the intended use. I'll just show you some examples of how a postbiotic might work. So here we can see a whole variety of effects ranging from modulation of local immune responses, enhancement of epithelial barrier function, modulation of systemic immune responses, and even signaling to the central nervous system. And of course, at least some of this may be based on modulation of resident microbiota as well, through modulation of their metabolism, for example. And as you will see later, many of these effects of postbiotics are very similar to those which have been proposed for probiotics. And this is one study, just an example. This is a recent study looking at a heat-inactivated bifidobacterium in irritable bowel syndrome. And you can see here that compared to the placebo, which is shown in red, the heat-inactivated probiotic, or postbiotic, I suppose we should really call it, shows a significant reduction in IBS symptoms over the duration of the study. And I think you're going to see more studies involving postbiotics in the years to come. Now, synbiotics refer to a mixture comprising live microorganisms and substrates selectively utilized by host microorganisms confers a health benefit to the host. And basically, in simple terms, it means a prebiotic and a probiotic. And they can be synergistic, in which the substrate is designed to be selectively utilized by the co-administered microorganisms, or complementary, where they're designed to target the intrinsic microbiome. Now, what I want to spend a little bit of time now talking about is where we've got to with this whole probiotic area. I won't talk anymore about postbiotics or prebiotics. So I want to talk about characterization, understanding mechanisms of action, clinical trials, regulation, and quality control. Start with characterization. I firmly believe that at this stage in science, characterization of any probiotic organism should be based on the full description of its genome. Not only will that allow you to characterize accurately what exactly you're dealing with, but it also allows you to predict functions. For example, in this particular instance of Lactobacillus salivarius, you can see here that they were able to identify genes involved in metabolism, etc. Now, the other very important thing that's happened, of course, is as genomics are being applied to many probiotics, you will see that some of their names have changed because it becomes clear that they actually are not exactly what they were supposed to be. This doesn't mean that they're not effective or active. It just means that nomenclature may change. Now, with advanced science being applied to probiotics, we've actually begun to learn a lot about them. And I just want to show you one example. So this is a bifidobacterium that we've been involved with for some years, the bifidobacterium longum, subspecies longum. And as you can see in its native form here, you can see a very abundant exopolysaccharide coat. And if you knock out the component of the genome for this organism, this bacterium, which codes for the exopolysaccharide coat, you produce these bifidobacteria, which are completely devoid of this exopolysaccharide coat. And this is actually the part that you're knocking out. But that's very elegant. But what's very interesting is that then when you study the organisms, both the wild type and the knockout model, in an experimental model, you find that with just knocking out that component of the genome, you've changed its function completely. So you, instead of having an anti-inflammatory effect, which you can see here with just looking at body weight, you see no loss in body weight in the wild type with the wild type bacterium, but progressive loss in body weight with the knockout model due to inflammation. And you can see here, this is also shown here in terms of immune response. So with this very simple, very minor, you could say, very minor change in the genome, you've changed the function of the bacterium completely from being an anti-inflammatory organism in the wild state to now being a pro-inflammatory organism in the knockout state. And the reason I emphasize this is that shows you how important it is to know exactly what you're dealing with when you talk about a probiotic, because you cannot translate from one organism to another when it comes to function. Now, when you're talking about evaluating a probiotic, there's some basic properties that you have to define. So in terms of in vitro and in vivo studies, you should define that again, based on the genome, that it does not contain any pathogenicity islands or any transmissible drug resistance sites. When you get on to doing in vivo studies, then you should show that it survives transit through the GI tract. If you want a GI effect, it obviously has to survive transit. It should be acid and bile resistant, and antibiotic sensitivity should be defined. And on the right-hand side here, you can see an example of how the lactobacillus survive transit through the GI tract. Then we should move on and try and define what is the mode of action of our probiotic. For example, does it compete with and exclude pathogens? Does it have antibacterial effects like producing bacteriocins or denaturing toxins? Does it enhance gut barrier function? Or does it modulate gut motility and sensation? Or are these immune effects like immune modulation, cytokine modulation, enhancing immunoglobulin A production? Are there metabolic functions like caloric salvage, production of valuable metabolites, or even participation in drug metabolism? Or does it modulate the microbiota gut-brain axis? So these are all functions that can be tested and evaluated in the laboratory before you even do studies in man. So let's talk about this in more detail. So here's a concept that's an old one for a function of a probiotic, namely adhesion. So the idea here is that the probiotic, when it's given, adheres to epithelial cells in the gut and thereby prevents pathogens from being adhered to the same cells and causing toxicity. Now, this is a more sophisticated mode of action of a bacterium, and this is what we refer to as a bacteriocin. A bacteriocin is literally a natural antibiotic produced by bacteria to protect themselves from other bacteria. And here's an example of a bacteriocin produced by a lactobacillus. This is actually looking at imaging of the liver. And you can see here when infected with Listeria monocytogenes, you see enormous uptake in the placebo-treated animals and no uptake or virtually no uptake in those who are pre-treated with the probiotic. And you can see this here shown quantitatively in the liver and in the spleen and the dramatic effect of the probiotic. Here's a study from a number of years ago, actually from France, showing the benefits of a probiotic in terms of enhancing or protecting against damage to the gut barrier. So this is a stress model where the colonic epithelial barrier was impaired by a particular form of stress, and this was restored by the administration of another lactobacillus called Lactobacillus parasiminus. Here's a study which actually came from Canada, from Hamilton, where they looked at effects on gut muscle and nerve. And what they're doing here is they're stressing the animal by inflating a balloon in the rectum and then measuring the stress response by looking at the heart rate. And you can see here that in the control animal, with increasing intracolonic pressure, the pulse rate or the heart rate decreases, whereas this stress effect does not occur in animals who are pre-treated with Lactobacillus reuteri, suggesting an effect on gut sensation. These are all animal models. How about in man? Now, this is a study which was done on lymph nodes harvested from individuals undergoing abdominal surgery. And this very nicely illustrates how a probiotic is different from a pathogen. So here we're looking at the effects of two potentially probiotic organisms, a lactobacillus and a bifidobacterium, in comparison to a pathogen, in this case, Salmonella typhimurium. And we're measuring in these lymph nodes the production of various cytokines. On the top here, we've got IL-12 and TNF-alpha, which are both pro-inflammatory cytokines. On the bottom, we've got IL-10 and TGF-beta, which are anti-inflammatory cytokines. And what we can see is with the pathogen, the Salmonella, we see a dramatic increase in the two pro-inflammatory cytokines, which does not occur with the probiotics, whereas in contrast, the probiotics enhance the anti-inflammatory responses, which of course the pathogen does not. So you can see here the ability of the human immune system to differentiate between a pathogen on the one hand and a commensal probiotic organism on the other. And actually, this is a human study we did a few years ago where we took human volunteers. They were fed with the bifidobacterium, and then we measured IL-10 in the serum 8 weeks later, and we saw a significant rise in IL-10 compared to placebo or compared to baseline. And of course, IL-10 being an important anti-inflammatory cytokine in the human body. And this was actually transferring this into a clinical situation. And here we're looking at 3 inflammatory conditions: psoriasis, patients with irritable bowel syndrome and chronic fatigue syndrome, and patients with ulcerative colitis. And we're measuring C-reactive protein, a very commonly used in clinical practice measure of systemic inflammation. And you can see here, compared to placebo in red, those who were administered the bifidobacterium saw a significant fall in CRP levels in psoriasis, IBS with chronic fatigue syndrome, and ulcerative colitis, whereas those who got placebo saw a progressive rise in C-reactive protein, reflecting the ongoing activity of their inflammatory condition. So this is a very nice diagram developed by my former colleague Liam O'Mahony, which summarizes how a probiotic is different from a pathogen. So here we've got the probiotic organism up against intestinal epithelial cells, and in contrast to a pathogen which induces an inflammatory response mediated by NF-kappa B and including various pro-inflammatory cytokines, the probiotic organism, in contrast, engages with myeloid dendritic cells, which are antigen-presenting cells. Again, they do not elicit an inflammatory response, but instead they engage with regulatory T cells, and through the production of anti-inflammatory cytokines, produce a regulatory T cell response, an anti-inflammatory response. Now, the other actor that's come into all of this recently is the gut-brain axis. I won't have time to talk about this in any detail, but certainly there is evidence that the microbiome can influence brain function and cognition and other central effects. But it's important to remember that this is two-way traffic, that the brain can also influence, through effects on the immune system, motility, etc., the composition of the microbiota. Now, how about clinical trials? Because at the end of the day, when you're going to use a probiotic in clinical practice, you want to know, does it actually work? And how you know that is based on clinical trials. Now, where is there data for value for probiotics in clinical medicine? Diarrheal diseases, such as daycare diarrhea, traveler's diarrhea, and antibiotic-associated diarrhea and C. difficile-associated diarrhea. They're the best examples. Necrotizing enterocolitis in children, inflammatory bowel disease, and irritable bowel syndrome are some of those which have been most widely studied. So here is an updated Cochrane systematic review of acute infectious diarrhea, which involved 82 studies, over 12,000 participants. Now, one of the points I want to make, which is going to come up over and over in any of these studies, is that the risk of bias in these studies is high or unclear, and there's marked heterogeneity between studies in study design, the probiotic uses, and also in the manner in which they're evaluated. And in this overall analysis, looking at all of the probiotics which were looked at, they found actually no significant differences between probiotic control or between the outcomes in children or in adults. However, when they looked at the risk of diarrhea lasting more than 48 hours, and this is the whole list of studies here, they saw a significant benefit in terms of probiotics in general. And the same applied for rotavirus diarrhea, which you can see here. Again, this is aggregating all of the data in a meta-analysis. However, there are other studies which have looked at single organisms or individual it's actually a combination of probiotic. Sorry, I have to go back. Can I go back one slide? I got it. Sorry. Yeah. So this is a very nice, very well done study, which showed actually no benefit from this particular combination in terms of overall, all the instances of diarrhea, looking at viruses only, bacteria only, etc., and also saw no reduction in the shedding of two of the most common causes of diarrhea, namely norovirus and this one here is Norwalk virus. So two of the most common viruses that shown so no particular effect. And this emphasizes again this whole issue of heterogeneity between studies and the importance of a specific probiotics. Now this is a systematic review of the use of probiotics in the prevention of antibiotic-associated diarrhea. And you can see here, but overall, there is a significant benefit again. You can see here for probiotics. And when they looked in more detail at what actually was effective, they found the Saccharomyces boulardii, a two-strain combination of Lactobacillus acidophilus and L. casei, a three-strain combination as shown here, and then another four-strain combination. So in this particular instance, they were actually able to define some particular probiotics or probiotic cocktails that were more effective. In inflammatory bowel disease, the story is fairly straightforward in that in ulcerative colitis, which is shown on the top here, again in a meta-analysis, there was a significant benefit for probiotics in the induction of remission, absolutely no impact in Crohn's disease. Looking here at the maintenance of remission, looking at ulcerative colitis, possibly a marginal effect, again, no impact in Crohn's disease, and a significant benefit in pouchitis. So again, we're seeing here differential effect for different forms of inflammatory bowel disease. And what I don't have time to go into more detail is that if you look at this in more detail, it seems that patients with mild, less extensive ulcerative colitis are perhaps those who are most likely to respond to a probiotic. And it may also be additive with other therapies for ulcerative colitis. This is the AGA, the recently published AGA clinical guideline, which suggested that probiotics were effective for necrotizing enterocolitis, for acute gastroenteritis, the prevention of C. difficile infection, and for the treatment of pouchitis. So this is a very recent data, but like all of these guidelines, there are always some issues with regard to the methodology, and not everybody would agree with the conclusions. Now, getting to quality control. So the first question you should ask when you're choosing a probiotic is, what is its origin? Is it of human, animal, or other origin? And why is that important? Because there's the potential for contamination with pathogens or for the exchange of DNA, for example, resulting in the transference of antibiotic resistance genes. I've emphasized characterization, and I've made it clear that I believe this day and age, this should be based on the genome. What is the appropriate vehicle? Because the vehicle may influence the activity of the probiotic. A probiotic, by definition, is supposed to be viable. So if you're buying a probiotic, you should be given information as to how long it is viable in the conditions in which they recommend it is stored. In other words, what's its shelf life? Does it have to be refrigerated? Can be stored at room temperature? Can it survive in very hot or very cold climates? What dose should be given? And this is a major problem because there are actually very few dose ranging studies for probiotics. And then the issue that comes up all the time, are combinations or cocktails better than single organisms? And the answer to that is probably both can be effective in particular indications, and basically it comes down to the data. Now, human studies have been performed, and more human studies are being performed, and more high quality human studies are being performed, but there are a lot of problems with interpreting human studies, some of which I've already alluded to. The strain selection often seems haphazard and not based on the type of selection process that I mentioned earlier. I've already mentioned that there are very few dose ranging studies. In terms of the formulation, why should we use a single organism or a cocktail or combination? Are we using the appropriate study design in terms of the desired patient population? Has it been adequately powered? Was the duration of the study adequate for the particular disease process that you're studying? In other words, if this is a chronic disease, it needs to be a prolonged period of evaluation. And are you using the appropriate comparator and using appropriate outcome measures? One of the big problems in this whole area is extrapolation between strains and species. So somebody shows that probiotic X has an effect in a certain disease state, and then people rush to say that every probiotic is effective. That may not be the case. As I mentioned earlier, very minor changes in probiotics, very minor differences in probiotics can mean significant differences in terms of efficacy. Now, one example of this, of this variance between guidelines is a review, well, not a review, but when I looked recently at guidelines for probiotics and irritable bowel syndrome. I know you're going to get a talk on this later, but this illustrates how even with high quality meta-analysis and systematic reviews, you still end up with divergence. So for example, in these three guidelines from the American College, the AGA, the British Society of Gastroenterology, and the World Gastroenterology Organization, three of them clearly state that probiotics in general are effective in irritable bowel syndrome. ACG couldn't differentiate between products. AGA, for reasons related to methodology, I assume, did not evaluate perhaps one of the most best published organisms in terms of irritable bowel syndrome. BSG couldn't recommend a specific strain, but World Gastroenterology Organization did recommend B. longum for improvement in symptoms and global assessment of IBS symptoms. Now, just to illustrate how a successful study can be performed and can produce results which are of very significant clinical impact. So this was a very large study performed in India on high-risk individuals, and it was involved giving probiotics to mothers and then following their infants. And these were high-risk pregnancies and high-risk births. And what it basically shows, and I won't go through this in detail, is that basically, and they were looking at really hard endpoints like death, serious infections, gram-negative sepsis, gram-positive sepsis, diarrhea, etc. And you can see here that those who were randomized to receive the Synbiotic, which is a prebiotic and a probiotic, had significantly better outcomes compared to those who got placebo. So here's a high-quality study. It was an expensive study, but showing clinically very significant effects for a Synbiotic. So in summary, we've certainly made progress. And nowadays, probiotics can be characterized in detail through in vitro and in vivo approaches. Genomic approaches permit prediction of function and standardization of product. More clinical trials are being performed in several clinical disorders, and that is to be welcomed. But we still have challenges. We need to be very cautious in extrapolating from animal models without performing human studies. For some indications, strain specificity has been defined. For others, this has not been performed as yet. We need more high-quality studies in man, and for the consumer, quality control remains a real issue because in the way probiotics are currently regulated, quality control is not what certainly I believe it should be. And with that, I am delighted to take your questions.
Dr. Quigley, thank you so much for amazing presentation. And I'm actually monitoring the chat, and I have lots of questions for you. To start, the question is, how important is strain specificity? And I believe you alluded that with saying if we have to go even beyond strain specificity to genome actually sequencing. So to follow that question, is it acceptable to combine strains that have evidence in isolation but not necessarily in combination?
Okay.
And so
I'll take that one at a time. So now there probably are some probiotic effects which are relatively non-specific, but there certainly are effects which are specific. And I mentioned some of those that went along. Now, the issue of combining two strains is a very important one. What the question is basically asking, if you're shown that strain A is effective and strain B is effective and you put them together, they should be great. That may not be the case. And I would suggest that if you, for any cocktail which may be effective, you must study the cocktail as it is and not just the individual components separately. You should define the activity of the individual components, but if you're proposing that the cocktail is what you're going to treat people with, then you must demonstrate efficacy for that and not just efficacy for the individual components.
Excellent. One of the questions that was part of this is what do we tell patients about substituting brand name probiotics for generics or store brand?
Yeah, this is very difficult. The problem here is that we often don't have enough information. So as I said earlier, if you're going to take a probiotic, we should know what it is, what exactly is in there, and that is it will be live for the duration of its shelf life, and you should know what it's likely to do and how it may benefit you. And if you can be guaranteed all of those, and that may be very difficult for the consumer to obtain, then fine. But I think, for example, when you come to trade or generics versus specific products, the problem with the generics is they may not have the same organism as was in the original. As you know, there was a major lawsuit about this in North America recently. So I think you have to be very careful when you're looking at generics. You've got to be absolutely certain that they have exactly the same organism in there, in the same amounts, in the same formulation as was in the product, which actually showed a benefit.
Excellent. Another question is that comes actually from Norway, and says that I've heard that if you take probiotic supplement regularly over longer period of time, there might be a risk of the building of what we call antibiotic equivalent in the gut. I think antibiotic resistant in the gut.
Yes. Yeah, this is based on a very interesting study which came out recently, which suggested that a particular probiotic product could do this. Whether that applies to other probiotic products, we don't know. Certainly, as I mentioned earlier, based on your interrogation of the genome, you should be able to define whether a probiotic has got any antibiotic resistance genes, which it could transfer to the native, the commensal microbiota. So that's something you can certainly do as a precaution. But it is an interesting observation, but as yet I don't know that it applies to other probiotic products.
Excellent. You also mentioned that there was a question about why wasn't a line 35624 included in the AGA review?
The answer to that, I'm not quite sure of this. I assume it's a methodological issue. So, and that's a very important point of meta-analysis, is that one of the reasons that meta-analysis come up with different results is that they apply different criteria for the inclusion or exclusion of studies. For example, they may insist that all the studies have dichotomous outcomes, and that may exclude certain studies. They may insist that you have at least 2 studies with a particular formulation. But in this particular case, I don't know. I did notice that it was not included in the meta-analysis, which is a pity. But it was included in the BSG, the ACG, and the WGO meta-analysis. But I would have to go through that methodology in great detail to find exactly why it was excluded. But I would imagine that it has something to do with their decisions with regard to what criteria they employed for the inclusion exclusion of studies.
Understand. There's a question, I believe it's from Croatia, and I can translate for you. So there was asking you to share your own experience in using Visbiome in treatment of ulcerative colitis.
Yes. Now I've got to be very careful here, because this is what used to be called VSL number 3, I think. Is that correct?
That is correct, yes.
And there's a lot of issues here around exactly. So if you take the cocktail that I used to know as VSL number 3, there is some data, there's a nice study from India suggesting that in mild to moderate ulcerative colitis, that it is beneficial. My own experience is limited to using it in pouchitis, which is a very specific form of inflammatory bowel disease, which occurs in people who've had a total colectomy and have had a J pouch created. And certainly there's good data that VSL number 3 can prevent the development of pouchitis in the first instance, and also can prevent the relapse of pouchitis following successful treatment with antibiotics. So all of my experience has been in that area rather than in the primary treatment of ulcerative colitis.
Okay, and again, I do invite the audience to join the Dr. Aline Charabati. We'll be talking about specifically IBD and probiotics. moving on. And again, one of the things that you mentioned, the VSL number 3 and Visbiome issue has been addressed, and we have addressed it in some of the guidelines, and our own guide has a statement about it. Next question is, how do you correct the many sites or quote unquote experts, fellow clinicians and media who clearly do not understand the importance of strains and human data and just call any mixture of strain probiotic, even fermented foods, when this is wrong?
I don't think I can do much about this. I can give you my opinions, which are here, but there's nobody else has any reason to listen to me or to adhere to them. Unfortunately, the only way this will get sorted out is by regulation, which of course we don't like. I actually would welcome regulation, which could clarify and make it easier for the consumer to understand exactly what a probiotic is. I mentioned earlier the ISAP, the International Scientific Association for Probiotics and Prebiotics. And if you look at their publications, which have come out with consensus definitions for prebiotics, probiotics, synbiotics, fermented foods, and postbiotics, then I think that gives you a firm basis for what you should be doing. But I suspect that many of these websites, blogs, etc., are not going to do that. They've got their own interests. So I think until we get some real consensus in terms of regulation, this is going to be a very difficult issue.
Absolutely. And again, we do at APROBio, we do provide some information and links to the ISAP website with the great definitions. There's a question, do you have a preference for when to give probiotics with antibiotic therapy, concurrent or after antibiotic?
That's a very important question. And there was an important meta-analysis recently from, I think, from the Mayo Clinic, which suggested that the closer you give the probiotic to the antibiotic, the better the results. And ideally, what I'd recommend is actually you should start use them concurrently and continue them then for at least 2 weeks after you finish the course of antibiotics.
Okay, there's a question about quality control and what consumers should look for right now, and what are the markers of quality, which I think you addressed. We need regulations for that for sure. Yes. There's a comment that as a registered, I routinely recommend Visbiome 112.5 billion cultures. It has been studying over these 15 years to see the number of people who respond to this well. Other probiotics do not seem to have significant effect, even if doses taken by another probiotic. I assume that must be with the combination of components. What are your thoughts? And I believe we have addressed that already.
Yeah, I think the if we're talking about the same entity, that's very interesting. That contains a number of strains, some of which have anti-inflammatory effects, some don't. They have been studied individually, and I think there was a study actually from I believe it was from Edmonton a number of years ago, that suggested that most of the efficacy, at least in the laboratory, of this preparation resided in a few strains, particularly a few bifidobacteria. So the combinations obviously need to be looked at, and combinations make sense. So if you're looking at a complex disease that has a number of aspects, and you've got one probiotic which looks at one aspect, one looks at another, then putting them together makes sense. But what I would encourage you to do is to study each component separately, study them together, and then look at the clinical outcome. So it's very tempting to say, look, if one probiotic is good, 10 is wonderful, but that may not be the case.
Yeah. And I think we are getting lots of questions, so I'll try to go through some of them, try to jump them together. So what are the best resources in choosing probiotic brand for a certain condition?
Well, you heard at the outcome, at the outset of this, the now I think yearly updates that you get from Dragana, the probiotic guides for the US and Canada, which refer to what's available in the US and Canada. Now, it doesn't reflect to the rest of the world, so I think that's a very good resource. ISAP, which we both mentioned, is a very good resource. It's got an excellent website. So I think they're two very good resources. So I've already highlighted along the way a number of meta-analysis and systematic reviews, which if you want to look at it in more detail, are also worth looking at. And of course, the other speakers, I'm going to tell you about liver disease, I'm going to tell you about inflammatory bowel disease, I'm going to tell you about irritable bowel syndrome, so a lot more to come.
Yeah, and again, to conclude, would you please comment on the importance of dose at time of expiration versus at the time on manufacturing?
Yes, this is very important. So what you want to see is that the dose at the time of expiration is at least as high as was shown in the clinical study. So if you have a clinical study showing that a dose of 10 to the 8th, say, just for example, is effective in a particular disease. What you want to see is that by the time of expiration, it contains at least 10 to the 8th. Now, most good products will actually overfill to start out with to make sure that even if you lose some along the way, you're still at or above the minimal effective dose at the time of expiration.
Absolutely. And again, there's a last question, I promise. Some physicians are afraid to give probiotics in acute inflammation because of the septicemia caused by probiotics. They say it's a rare but critical condition and they are not willing to take the risk. What can we say about taking probiotics in acute inflammation?
It's a great question. So I'll give you some examples. Now, there was a study a number of years ago which caused a lot of concern, which was in acute pancreatitis. And that involved patients who were extremely ill. They were in the intensive care unit with acute pancreatitis. And they found that the mortality in a randomized trial was higher in the patients who got probiotics compared to those who did not. But the problem was due to bowel ischemia, and it's never really fully explained why that happened. But I can tell you that there have been numerous studies in acute inflammation related to ulcerative colitis and in Crohn's disease. We can argue about how effective they were, but one thing I can tell you is that I know of very little, if any, data to show that they actually led to septicemia. So I think you can be reassured, at least in inflammatory disorders of the gastrointestinal tract. I think I would be cautious with pancreatitis until we resolve exactly what went on in that study.
Dr. Quigley, I really appreciate your time. And on behalf of the Alliance for Education on Probiotics, I really like to tell you that you taking the time away from your patients and in this busy day, spending lunch and learn with us, it's really greatly appreciated. And again, I also like to thank Exegi Pharma for funding this event and for you to joining us. So again, remember that the clinical guide to probiotic products is always available to you as a printed format, as a booklet, or as online website, or as a smartphone app, easily accessible and free of charge. Also visit the Probio website. You have links to the clinical guide, links to ISAP website, and all different grades of resources that you can use and share with your patients. Again, finally, we are here to support you. We strongly encourage you to complete the survey at the end of the presentation. And again, once again, thank you for joining us. And this concludes our session.